Through the 1980s and 90s, Clinica Family Health Services was a relatively small community health center, serving about 4,000 patients a year. But in the mid-90s, a huge influx of people moving to Colorado and changes in the Denver health safety net system caused Clinica's patient census to explode. Health outcomes were suffering. A new approach was needed.
In 1998, we were invited to participate with the Institute for Healthcare Improvement and HRSA, which is Health Resources and Services Administration, to participate in a new collaborative to see if we could improve care to patients with chronic disease. This was based on Ed Wagner's model, and the very first collaborative included one community health center from each of 5 regions in the country. And we participated in that, and it was focused on diabetes care. And as we tried to improve our diabetes outcomes, it became immediately obvious to us that we had many barriers built into our systems, which actually made patients' health worse.
In the old system, when I first started at Clinica, the providers were in one corner of the building. We have a very big building here. The providers were all housed in one corner. The MAs were all housed in another corner of the building. The nurses were in the third corner. Medical records was centrally located. And we have a big square track, essentially, around our building, and we would all run around looking for each other. So when the provider needed their MA, and their MA was not right there with them, the provider had no idea of knowing where the MA was.
The concept of co-location was sort of floating around in redesign meetings that we were going to, and that coupled with the desire of patients to see smaller groups of people encouraged us to think about redesigning our practice into smaller teams that were essentially small practices within a practice.
The clinic needed a physical structure that pulled staff together instead of keeping them apart. The architects at Boulder Associates understood the idea and designed a clinic that eliminated many walls and most individual offices. They created the pod model that allowed clinicians and support staff to work side by side and see their exam rooms from their desks. And they created a clinic that felt small and personal to patients.
We decided the only way to grow was to grow in smaller units or pods, and then have patients really attached to those teams of providers, so that instead of maybe seeing any 6 people at the front desk, they would only see 1 or 2. And that gave us that feel that they were looking for, of the clinic staying small even though we were growing.
The implementation of the pod, or the care team system, allowed us to bring the people together in care teams that take care of the patients on that team. So that includes, the care team includes the providers, the nurses, the MAs, the behavioral health staff, the medical records person, case managers, front desk. Everyone is right there together, and they all sit in the same location, and there's actually no barriers between any of them. They're able to see everyone on that care team at any moment. If they need medical records, their medical records person is right next to them, and it creates an environment where there are no barriers to communication for care.
Our physical structure is such that there are barriers around the pod, and the top level, which is the patient's eye level as they're walking by, is glass. So they can see what we're doing, but we're HIPAA protected and mostly sound protected within the pod about the topics of conversation that are going on, and we try to be sensitive to that.
And we found that really the only people that need to be on the care team are the people who are taking care of the patient. So our financial screening staff are no longer on the care team, and our managers our operations managers don't sit on the care team. Preparation for our appointments, because we don't know what they are in advance, we do have what are called daily huddles. And the process of daily huddle, it's a planned care process where the staff meet together for 20 minutes, review the appointments that are coming into the clinic, and prepare and plan for what's needed.
In the huddle, everybody's present. There's the front desk, there's providers, nurse practitioners, MD, there's MAs, there's medical records, the nurse, and ECS. So in a sense, you have everybody, you have an integrated team within your reach. So by email, you're not sure if somebody is reading what you're trying to get across. So in a sense, the huddle, I think it's a good way of communicating with the team members as to what everybody's job is for that particular patient.
The patient checks in at the front desk. The MA brings the patient from the waiting room to the exam room.
Cierra la boca. Ándale, muy bien. Gracias.
The MA has vitaled them, weighed them, and then everything that patient receives that day for care, we take to them in the exam room. So instead of us sending the patient out for lab draws or out to see a case manager because they need help getting on WIC, we take that staff to the exam room and we provide the care for that patient in the room. So the patient doesn't move throughout the clinic, we move to the patient. Probably the best feedback that I've received from patients regarding the pod model, the thing that they love the most is that they actually now know the people that they are dealing with. When they call up and they need to leave a message, they know their nurse's name. When they come in and they're at the front desk and they check in for their appointment, they know the front desk. It's the same person that they've been checking in with for years, and they get to know the person. We use flags that indicate which rooms have patients, which rooms the providers are in, which rooms the MA may be in, which room the nurse might be in with the patient, and it provides extremely easy communication for the team.
And so we set up exam rooms so that we could use the flags to notify one another that there was work to be done. So the way we use the flags is if the flag is directly out, that means that that person is needed in that room. And in this case, it means it's the first patient ready for the provider. If the red and the white flags are out together, that's the second patient in line. And the red and the yellow flag means that's the third patient waiting. The green flag is for us to get some help with financial screening problems or having one of our office techs help us around issues of managing patients' questions they have around finance. The blue flag would mean that the behavioral health person or the case manager is in the room with the patient. And then finally, the black flag is for our medical assistant. So if we had the flags like that, that means that the medical assistant and the behavioral health professional was in the room with the patient. So from my desk where I do most of my work, I can see all the team members on my team if I need to ask for help or hand off a piece of work, and then I can have line of sight view to the flags on the room so I know when it is that I'm actually needed in a room and when the patient's ready for me for follow-up. On each pod, we've built a mini lab, so we've put our services on each pod to make it more efficient to be able to care for patients. In our labs, we don't actually have drawing stations or places for the patients come because we do all of our lab work for the patient in the exam room. So the patient comes to one room and gets all the services from that room.
Before having a pharmacy, Clinica physicians individually dispensed medications from a storeroom using their own DEA certificates. Bringing a pharmacy and full-time pharmacist into the clinics has freed up so much time for clinicians that they are able to see an additional patient every day.
When I hand my low-income patient who does not qualify for Medicaid and might have an indigent care program or a gap coverage insurance program, a prescription, I don't need to try to look for prices at Walgreens or King Soopers. I can send them downstairs and they pay the equivalent of the VA rate since we're a FQHC. The best thing for me as a doc being on a pod with a shared work environment is that I sit right in front of my medical assistant. I know that she's there sitting across from me, or if I look around and I have 3 rooms and I look at those flags, I know exactly where she is. And for me as a provider, sitting across from my MA is priceless.
In order to improve workflow on our teams, we did a lot of early work mapping where we would actually wear pedometers and move the fax machine closer to the nurses and then closer to the front desk in order to see what actually was the optimal place to be locating a lot of the equipment that we used. And we also knew we had significant bottlenecks. We would have only one big copy copier in a clinic, and people would have to leave the pod and go clear to the back of the building in order to make copies. And we just found it was better to get smaller units and put them right where the work was being done.
Much of healthcare is about patient education. The nurse team manager can help here, too.
I would consider the nurse team manager one of the most important positions on the pod as far as managing flow.
Our nurse team manager has many roles and is in a lot of ways a jack of all trades. Most importantly, they provide clinical care under their nursing license and will go into a patient's room and see them solo if it's under their nursing license and protocol. What they can treat patients for example, an ear infection, a bladder infection, they can do that all on their own.
My primary job is to do triage and provide access to our patients. So if a patient needs to come in today because of an acute issue, or they just need to come in because they have transportation today, they have the day off, or they have transportation. If there's no appointments available, then what I will do is I will work with the provider to do what we call a co-visit. I bring the patient in, work the patient up, meaning vital signs, labs that might need to be done, do an assessment, and the provider will go in to verify my assessment and confirm. And instead of the provider spending 20-30 minutes with the patient, then that cuts, by me doing the co-visit, it'll cut the time, his or her time, to maybe 5 minutes with the patient. If someone comes in and they're being started on insulin and they've never been on insulin before, then the nurse will also jump in to do the insulin teaching, talk about supplies, how can you get supplies, what's the cost of the supplies, maybe even do a glucometer teaching at that visit in conjunction with the MA, the provider, and ECS.
The flow of what happens on the care team during the day really can make or break your day. Managing that flow is one of the most important things for staff satisfaction and patient satisfaction, because when you don't have good flow, you have waits. And as we all know, waits are not a good thing for staff or for patients.
Like many clinics, the staff at Clinica's front desk had to juggle many tasks. They had to check in patients, collect payments, answer questions, and answer the phones. The ringing phones were frequently the lowest priority. In 2007, Clinica tackled this inefficiency by creating its own call center.
I was actually one of the ones that used to answer the calls and schedule appointments on the pods, which are the teams that we have at each clinic. Patients used to wait a very long time when they used to wait for me to schedule their appointments or direct them where they needed to go. Now, once we got the call center, it's just awesome. Patients do not have to wait that long. Call center attendants are actually trained to take care of any patient that calls and make their appointments at any of the clinics.
Good afternoon, Clinica Family Health. This is Naomi. How may I help you?
If a patient calls and we have no appointments available, what we do is we open a patient's chart, we check their demographics, and then what we do is we let them know that we have nothing available today. If they would like, we can send a message to the nurse to see what they can do for them today. We like to take care of today's work today. We'll go ahead and send a message to the nurse and let them know they will call them as soon as possible.
The call center will usually call us on our cell phone if it's something urgent. They bypass taking the message and sending a task to us on our electronic medical record. And so they'll call our cell phone and we will talk to the patient and see if they assess the patient, if they need to come in now, this afternoon, or possibly go to the emergency room.
Our typical wait time is around 2 to 3 days. And there are some providers in the clinic that they have very close to same-day access. We used to use a system of scheduling where we would open the schedule 3 months out, and patients coming in for well exam care or any sort of well care would be scheduled as far as 3 months out. The patients who scheduled so far out for care would forget about their appointments, and the patients would no-show for appointments, and at that time our no-show rate was around 33%. As a result of implementing open access scheduling, our no-show rate has dropped from about 33% down to about 8 to 10%. which is also important financially. No-show, we have a huge demand for appointments here in this clinic, and we actually have a wait list for care. And so when we have a no-show appointment, or we've taken up an appointment slot and not utilized that, that's actually denying care for someone else who could have used the appointment. And so as a result of that, we're actually able to see more of our community. And also, our patients are getting the care that they want and they need when they need it, so it's more convenient for them. And also, as a result of that, our patients show up. You can't create a healthy population of patients if they don't come into the clinic.
Finding a better way to manage patient information was the final piece of the efficiency puzzle.
We had stacks and stacks of paper charts, and we worked hard to make those be a valuable record of the patient health information, but sometimes you couldn't even read the note that was written in the chart. Sometimes pieces of paper were not be filed in the right place, and we would waste a lot of time going through the chart, trying to find a lab test we know was probably filed in there. And it was important to us to be able to have a better way not only to document the care we were giving, but it actually allowed us to apply some decision support for providers. So it would remind us or our medical assistants or the nurses what care was indicated and needed to be done then for the patient, something the paper chart could not do at all. And then we also added other decision support so that if people wanted to look up things right from the patient's record, we could do that. Not only are there advantages to the provider, but patients realize a tremendous advantage. First of all, there are a lot of patient safety issues which are improved by having a record you can even read. The electronic medical record never forgets a lab test result. It never loses a healthcare diagnosis. And those things might be buried under 2 inches of paper in a paper record. Those things really helped us not only document what we did, but the other side of that was to help us make the right decisions for care.
We have a lot of lessons learned that we can share as part of our evolution from our old system to our new system, both related to moving into the advanced access model and moving into a care team based care. And that is that you really have to understand that it's not going to be something that you can change overnight. You have to really dedicate time and energy into the project, and it's something that you have to work on sustaining really for the rest of the time that you have your clinic open. It's not something that you can implement and then you can go away from that project. It's a constant evolution.
We have no question, we have data that shows that we added the equivalent of an additional pod's worth of patients by just redesigning and making our pods more efficient without adding any providers.
I would never go back to an individual office scenario instead of having the pod. The benefits so far outweigh the drawbacks to the pod. And I think that the drawbacks are all things that we've managed to work with. And every day on a daily basis, we experience the benefits of working so closely with our teammates. The patients get better care, we're happier for it, and we feel more like a team when we're working together.
The side effect of all these changes is that patients are healthier. And that's really our job. That patients are better, that we have fewer diabetes complications, that we do a better job of controlling hypertension and see fewer myocardial infarctions. Those things make it worth it.
The changes that we've made in the organization related to how we schedule appointments, the care-based teams that we've done, the efficiency that it's created has not only created a nicer environment for staff, a much more cohesive staff as a result of that. It's also enormously better for our patients and our health outcomes for our patients, and we're creating a healthier community as a result of that.